Any of these links or in the chain of transmissions will stop the virus from spreading, and it is an essential component to reensure containment. Each link of this chain provides a unique opportunity to leverage an innovative approach to containing contagions and holistic targeting the components at the work system. The built environment can play an important role in stopping the transmissions of pathogens. Yet, it is often an underutilized strategy with the overall work system. Our environments are full of surfaces, instruments, equipment, and textiles that can act as fomites. As we navigate through our built environment, we leave traces or prints. These surfaces can become a pathway for pathogens exchange, acting as a reservoir for the viral transmission. The traces that are left behind on surfaces can be distributed within the environment due to changes in the natural and mechanical airflow and human movement, potentially increasing the number of surfaces containing the pathogen. Potentially, an additional and innate property of surface materials can also mitigate the length of a time in which pathogens are able to stay alive in the surface. In leveraging the built environment to break the chain of transmission, it is important to minimize the traces we leave behind. At HKS, our researchers have created this basic graphic of addressing to the break of transmission in the built environment that it addressed with a system approach. We propose a nested system approach that individual organizations can deploy. First, in the level 1, policies and protocols or operationals. Next, at the environmental scale of building, and finally, at the level of a personal agency individual. Today, we will show you some possibilities of policies and protocols and the building interiors to achieve not only a physical, but a psychologically safety as well. On day 1, we will speak to you on day 1 and day X. We feel like day 0 in the hospital systems, it really never happened because we were taking care of patients. So we will address day 1, we will return, and with the volumes returned to the healthcare systems. We are addressing this with the following slides will address the organizationally protocols and the building systems for both days 1 and X. The purpose of these recommendations is to return the sense of safety and refuge that healthcare system offered before the pandemic. In day 1, you are able to read, so I'm not going to read all of them, but just show you some of the highlights that we are seeing as a component, and then we will show you of how to address this in the built environment. One of the things that we are recommending in day 1 and day X is to have a thermal evaluation of everyone who comes to the institution. Now, these protocols are suggestions for American-based hospitals, which it has an increased level of visitors that others in another country.
Excuse me, Anna.
Yes?
This is Ahmed. Sorry for interrupting.
No, no.
We would like you to share your screen with us.
Oh, it's not sharing?
It's not sharing, no.
Oh, I apologize. I thought it was sharing already.
No.
My apologies. Thank you for, you should have, okay.
Okay.
Okay, the host disabled the participating screen sharing.
Okay, Ibrahim. ابراهيم لازم تفتح السكرين
نعم يا
شير.
باشمهندس، مفتوح مفتوح.
It's open for you.
No, it says the host disabled, and it's okay. And it's still host disabled participant screen sharing.
ابراهيم سمعت؟
سامع يا باشمهندس، في شير، كلمة شير تحت. Can you open from
Go
share
to the
from
bottom.
share screen?
Go to the bottom.
Yes,
There is a
I
green.
am.
Yeah, share screen.
And
I
press share.
am. And when I press share screen, it says host disabled participant screen sharing. And then I said, okay. And then I tried to do it again, and it's the same thing.
Oh. ابراهيم.
يا باشمهندس.
شوف لها حل دي عشان
مفتوح عندي الشير. شير سكرين.
عندها مش مفتوح.
طيب. Can you share now?
No, sir. There we go. Now I can. Thank you.
Okay. Thank
Sorry
you.
about that.
That's quite all right. Let me just go back really briefly so people can see the, you know, what I was speaking about. This is the one when I spoke about recovery and taking the day 0, day 1, day X, and day XX. This is the framework, and for today's presentation, we will speak about day 1 and day X. These are the 6 spots that we consider to have the chain of transmission. And like I spoke before, any of these transmissions that we can break with the built environment will considerably help a great deal to minimize the virus. These are all just an explanatory of how many places we touch when we are in the built environment. The basic principles of recovery framework that we speak about, it is with the policies and protocols and building the interiors and the individual and everything living with a technology ecosystem and the communications ecosystems. Today, we're going to speak about policies and protocols and building interiors. A closer look to day 1, it is to establish a discrete and professional reminders about how the spread is airborne, this virus is spread airborne, and how to develop system policies and considerations to have everyone taking their temperature as they walk into the space, and also in doing this in a very professional way that it will show everyone that every step has been taken to promote their safety and their well-being for the staff, the patients, and the visitors. In day X, it is almost the new normal. This will happen after 6 months to 2 years. It will require some small renovation, but not a lot. We are also approaching day XX is when we are starting a complete renovation or a new construction. But in these things, it will require in day X, it will require some investment from the organization. And I will show you at the end some examples of how to put these recommendations into practice. So first, we're going to do in day X and day 1 and day X. In both cases, we're always asking to provide a health screening before you go into the environment, and that there's always been a thermal screening, and of course, provide PPE and hand sanitation station. In day 1, we are proposing a footwear sanitation station on the floor. But in day X, where, for example, we need, there's been a little bit of renovation, then we perhaps screen a walk of grid system at the vestibules. That is at least 10 feet long to adequately remove all of the particulates from their feet. Considerations in receptions and elevators. In day one, we are asking for an acrylic divider that anyone who is approaching the reception, they will be protected for both the staff member and the visitor. And always have hand hygiene stations for all the visitors. And then minimize the elevator overcrowding. We recommend in day X, for example, to put 2 decals on the elevator cap floor in diagonal corners so people will keep the proper distances. In this case, we do know the staff will not wait for the elevator, so they will probably take the stairs, and we are recommending for the ventilations of the exit stairs to be increased. For the planning considerations of registrations, restrooms, and corridors. In day one, we are recommending to decommission all forced air hand dryers, but in day X, we're recommending perhaps to replace them for a hands-free paper towel. We will also recommend that everything will come hands-free, whether it is the touchless faucets and soap dispensers. And so these are just, and you have, and you can access these after our conversation for more detail. The planning and considerations for cafeterias, nurse stations as staff areas. These are more into having a cafeteria for the staff and cafeteria for the visitors. We're also promoting hand hygiene stations and sanitizing wipes near the tables where you're going to sit down, so everything could be clean. And we are also asking for in day X, perhaps to arrange and go stations for food orders without lines. And as well as many of the new hospitals have a decentralized nurse stations, to perhaps those are more utilized than the existing nurse stations. These are additional considerations for patients, staff, and the building. The other ones will be very similar to what we spoke before. And now the building is the one that I am going to just spend a little bit more time. It is for the HVAC filters, the EVS storage room, and each floor unit adequate supplies and motion sensor. Optimize the airflow distribution, like I mentioned, in the stairways, and increase the filter efficiencies and implementing the UVGI HVAC systems. That will contribute to minimize the contamination through the HVAC. Additional considerations for operations, it will be in the signage, to have a very clear signage, and always follow the CDC guidelines as they evolve. They change daily. We are proposing also for your clinic by EVS that should always be witnesses by the patient and the public. In the past, our EVS and clinics was at night. Right now, because we know that people want to be reassured that everything is being clean, that they see the cleaning of the EVS people all the time. Materials and finishes. Our hospitals are very well designed. It is a non-porous surfaces, and in the case of United States, we are asking to eliminate all carpet. In the Middle East, we know we don't have much carpet. And if it's possible to provide an integral cold space. In ceilings, they should be all smooth and scrubbable. And the counters should be a solid surfaces with bleach cleanable. And additional considerations in walls, and to eliminate any reveals, if possible in cubicle curtains, to remove them, or if not, to have disposable curtains. or clean the protocols that every cubicle curtain will go to cleaning after each patient. In furnishings, a non-porous furniture should be always recommended, and the arm caps should be polypropylene or a solid surface arm cap for ease of cleanability. And the outpatient pharmacies, we encourage a lot to be used in a way that there is a digital electronically for pickup, or also, if it's possible, to deliver it in their home. There is here some useful links that they will be provided later on of sites that they have really helped us to bring these conclusions based on research. Now I have a quick, I'm watching my time, a quick presentation of how we can address these guidelines that we have offered. In the ground level lobby, and here is our existing ground level, and how they could be the new level where we can present in the benching, just because we cannot remove those, for them to give them in a professional way that they can have their system sitting. Also, we are recommending that we decrease the capacity, but in a professional way that it still gives you the sense of that is well thought out, and we can still host our families. And then when everything, the demarcations here, that it is the acrylic, and they have a temperature control, and then some screen for UV screens. The main public, this is the dining area that we can, this is existing. As you can see, is a very dense because they do have a great deal of volume in this facility, and how we are recommending for, sorry, my computer is, we're recommending for day one that the main public lining to reduce the amount, to remove the furniture, and to less the density, and perhaps to scatter, do second shifts for lunch. We're also proposing in the elevator lobby, I'm sorry, my computer is being very slow, the internet, I guess. In the emergency department, we are proposing to have perhaps a temporary walls, and the manufacturers who can make it to put immediately separate from the vestibule the sick, what we call sick, is that they have a high fever, from the other individuals that they might have an injury. In the elevator lobbies, again, we are demarcating that it's only 2 people per person, 2 people per elevator. And then also we are asking to reduce the capacity of sitting. Surgery waiting area. Also, we are proposing to, this is the existing, and how we can do it in day one. Still always remaining that it will be families that they're coming here, so respecting also the families want to sit together, but perhaps adapting other furniture with some partitions to prevent the transmission. These are just some recommendations of professionally showing through signage what the organization is doing. These are some products for consideration. We are not proposing that these are the manufacturers, but they are some that you can see, some acrylic dividers or portable screens. These could be used as for circulation, or if you want in day eggs to change your seating, there is some mesh cover with copper to also avoid the virus and the bacteria to stay. And then there's some about touchless disinfection and sanitation station, as well as the amenities for hygiene stations. In furniture, we are also proposing to, again, like I show with the backings, to give you a little bit more protection, as well as they want the footwear sanitation station. So these are some of the recommendations, and if you would like, after our meeting, I will be happy to distribute the manufacturers of these recommendations. Thank you very much. Right now, I'm going to give it to my colleague, John Abdoulos in Detroit.
Can you hear me? Yes? All right.
Yes, we can hear you.
And can you see my screen?
Yes.
Okay. We'll go from the beginning. All right. Well, thank you all. Salam alaikum and Ramadan Kareem. What I'm going to do is present a facility that we were working on with the Army Corps of Engineers here in the United States, and we converted it into a field hospital. And what was interesting about this is that when COVID-19 first came about, and we started looking at stay-at-home orders, and a lot of us, the majority of us, are all working from home, HCAS began to look at how to convert schools, how to convert hotels, how to convert convention centers into field hospitals to help alleviate some of the pressures that the hospitals were starting to feel, with a lot of patients coming in with symptoms related to COVID. And there is one convention center that is actually very close to the HKS office here in the Detroit area, and we're actually located 35 miles, about 50 kilometers northwest of Detroit, in a major suburb. And I had reached out to the city mayor and to the government officials because I'm on the city planning commission, and I indicated that if there is anything that HKS can do to help out with this situation, especially with this convention center that's close by, let me know. Then about 3 weeks later, we find out that the federal government had selected this as one of the sites, and lo and behold, you need to be careful what you wish for. And we ended up with this project. And the project was given to the contractor on a Sunday evening, close to midnight. By 9 a.m. the next morning, we all had to be there for a meeting. And 14 days later, we were done with the project, and we turned it over to the Army Corps of Engineers, who then turned it over to the state of Michigan, who then turned it over to 2 health systems that were operating the hospital. So we're calling this a field hospital, and I'll go through why they selected Michigan, and then this is the conversion of the convention center, and then there's lessons learned from this, and it actually kind of dovetails into with what Anna had spoken about related to getting a facility ready for visitors and for staff, and implementing different things that you can do. So why Michigan? They were looking at numbers. So at the time, and this is at the middle of April, Michigan was the 3rd highest state with the most amount of confirmed cases and deaths. They were not only looking at it state by state, but they were looking at it county by county. So you look here, the first few counties here are all New York and New Jersey, and then you go down to the bottom here, Wayne County. That's where Detroit is located, and they saw a large percentage of cases and deaths. So they targeted that area to take a convention center and create a field hospital. They did 2 of them. They did one in Detroit, in the city of Detroit, and they did one in Novi, Michigan, which is the one that we worked on. These sites should only be really used for low acuity patients. The patients that have high risk factors based on age or pre-existing conditions, they should be admitted to hospitals. However, the recognition that this acuity level of trying to not have the hospitals be overloaded was one of the factors that not only this area, but all across the United States and around the world. I know that England and in Germany and Canada, a lot of countries are implementing this, where they take the large facilities and turn them into these field hospitals. So the need was to make sure that you find a facility that has all the infrastructure, that has the mechanical systems that can handle this, has communication systems, has standby power. So they investigate a lot of these areas across the country, and then they pinpoint certain facilities to be able to handle this. The information and the data that is collected is what helps to inform this, and CDC then collects this and creates guidelines. So all of this was presented to us, and we were looking at making sure that it was implemented and put into place with the facility that we were given. More data was provided. We were looking at the counties that had the most cases versus the low density counties, and that's where a lot of the information was gathered. This is just showing different data that's based on, and this was just an example of using New York, because at the time that was where a lot of the cases were, so more information was coming out of that. So we ended up kind of looking at the same thing for Detroit. They're constantly looking to make sure that they're not overloading their staff also, because when you create these field hospitals, you also have to have staff to be able to monitor and be able to service, you know, all the patients that are there. So again, just some more data. It didn't matter how old you were. It didn't matter what you know, age you were at, what ethnicity you were, your, you know, how much money you made. It was going to affect somebody that you may know, or someone within your own family, and so that's why it was important to do these as quick as we could. So this is a map of where the show place is, this convention center. Fortunately, there's the reason that they selected it is there's a hospital that is 1 mile away, about, you know, almost 2 kilometers away from the facility. HKS office is right here. This was only 6 kilometers away. I live here. Camila, one of our planners, lives here. We had Natalie and Vince and Alina. There's the group of us that actually live within 8 to 10 kilometers of the facility was what really helped make this facility work, and how we work with the contractor. It was 24/7. It was 14 days, so it didn't matter. If the information was needed, we provided the information. So this is what the facility looked like. They had a second level mezzanine that allowed us to look over this, which was really nice. They closed it off, I think, the last 3 days, because then they had to get air balancing done. They were trying to provide negative pressure to the facility. In the beginning, they were going to do like ICU type rooms, but that wasn't going to work with what they had, and the acuity level wasn't going to be at that rate that they needed to do that. What they did was provide us this plan. So this plan was developed by the Army Corps of Engineers. It was cut up into 3 zones. This zone A is the entry zone, so all the ambulances, patients would come in through here, get triaged, and then they would be placed into an area, and they broke it up very nicely. These 2 areas here were set up more for those that had a little higher acuity, but not to the point where they shouldn't be in a hospital. This layout here is set up for 1,100 beds. That was the original intent, about 300,000 plus square feet. So this is a convention center. This area here to the right is the beginnings of banquet facilities, and then further to the right off the page, there's a hotel. So this is it's kind of a self-contained area to host many different events. This is HKS, our team at the facility. We had a space amongst the contractors and the subcontractors, so we worked side by side throughout the day. That's Vince, who was our on-field construction administrator. And it's important to have someone there that also has Revit skills. I selected a team. This is our project architect, Eric. He also is very adept at Revit. And then our planners are all the same thing in Revit. And we'll go through that and we'll understand why that is important. We had our daily schedule. You could see it's marked down by days. We had different, so even like sticky notes that indicated what was hot, what was warm, and what was cool. So we knew what they wanted right away. We knew what was coming up, and in this area where it was cool, we could get our teammates to work on it as people were waiting. Every morning, there was a huddle session. The contractor, the architect, everybody would gather up every morning. You see that we're all like 6 feet apart. We all had our face masks on. We try to keep our social distancing, but trying to work together at the same time. This is where we kind of said, okay, today we're going to be doing this. This shows the evolution. We had that big plan that I showed you. It's a sketch that we would come up with. We would lay it out in Revit, and then what we did was we made the plan that they gave us was in AutoCAD. We converted it to a Revit model. We put it on BIM 360 so that everybody had access to it. This was a design build project, so the contractor hired subcontractors in order to do the mechanical systems, electrical systems, plumbing systems. They would all do it on in the Revit model. We would all check it. If there were questions, we could answer them right away. Then from that, we did quick approvals. They created their shop drawings for their ductwork, their piping, and then that's how they would order materials. And it was everything was overnight and very, very quick. We created a phasing plan with the contractor, and you could see how they did like a phase 1 and then a 1A and 2A. They identified what needed to be done in each phase and which days they were to get done, because the other thing was that they did not want workers working on top of each other. So you still had to maintain the social distancing. I will tell you, my first couple of days there, I was very apprehensive. I did not know what to expect. I didn't know, if I was going to get infected. But we all, wore the mask. We continually, washed our hands. We abided by all the protocols. Everybody was very respectful, and it turned out to be something that I personally will never forget. We also had to meet life safety. So we took the plan. We identified where we had all our exits, where we had all the fire extinguishers, where we would look at some of the main entry points. And then we had to review this with the local fire officials and the state fire officials. They didn't approve or disapprove. They just wanted to understand what we were doing, so we weren't blocking exits. We were allowing the flow to happen, and that they were comfortable with it. These are blow-up areas of those certain spaces within the plan. The patient area was a 10 by 10 station. It had a nurse station in between. So this is basically like a little ward setup, 2 hand washing stations on either end. We created 10-foot wide corridors instead of the 8-foot because we're anticipating maybe a lot of traffic going back and forth. This was the 15 station, almost like an ICU area, and it was going to be negative pressure, different than the regular large space. But then as they were looking at what they needed to do, they just made this more of a ward area, and there were going to be 4 nurses for this 15 patient station group. The patient areas during their construction were basically, like I said, 10 by 10, but they were using walls, really thin walls that are used at trade shows. They had just an oxygen. They had a light and the bed, and then a little a side chair, and then this is like a porta potty, and very, very basic. But again, this is a temporary situation to help offload the hospitals from the higher intensity that the hospitals were going to have. And so this was just to keep patients here. The other thing they were doing too is patients who were at the hospital that were being treated for COVID, but not yet ready to go home, they would come here for a couple days and then be discharged. This is an example, not at this facility that we did, but if we wanted to get into higher acuity, if we wanted to create tighter spaces, we would create these tent-like structures where you could individually control the negative pressure and the air changes in each one of these. But fortunately, we didn't have to do that. We had to create spaces like the pharmacy and look at how those things were laid out. So they would give us a block. We would go in, and you could see this is from our Revit model. We would design it and lay it out, give them dimensions. They would try and do everything as much as they can prefab and portable, because time was of the essence, and they wanted to get things done. But we would do the design, give it to the contractor. The contractor would go to the Army Corps of Engineers. The Army Corps of Engineers would say yay or nay. If it was a go, they would go. And at times we would give them a sketch, and by the time we even talked about it, they were already building it. This is an area where we had staff, when they came in, they would come in this way, they would change into their PPE for the day, and then they would enter the space. And then the most important thing was when they left, they would come in through this area, they would change here, remove some of their gear, remove some more gear. They would go in, take showers, and then exit. So they wanted all the staff to be cleaned before they left. And then this is another way of doing the donning, where they came in, and then this is their cafeteria area. So they had a way to take off the PPE, they could eat, and then put new PPE on and get back into the space. So all this, it's almost similar to what Anna was talking about, looking at how you enter the space and then how you're leaving the space. And then this is what we ended up doing at the end, where we came in to an area. There was a separate men's entrance, a separate women's entrance, separate showers, separate showers, come out to an area, then you leave, and then you exit the building. So very, very controlled condition. Again, different areas of design for patients coming in and for patients exiting. Then what happened on day 6 was they decided that, as with looking at the numbers, they went from 1,100 beds to 250 beds. So what we did was we concentrated our area on this. We still left all these other areas, the ancillary areas, in those spaces because they already had started construction on that. So they're down to 250 beds. When I said mobile, they were bringing in portable showers. They would set them up, and then we would build spaces around them. Any spaces that required 1-hour ratings, we would build 1-hour rated walls. We were FGA guidelines for this project. This is raised platform because we put showers here, and they had to have it raised so that they could provide for drainage of the showers. Right now, we're going to go through some daily progress. So this is the space. They're already starting to mark things on the floor, get things ready. They ordered, here we have some famous home improvement centers, Home Depot and Lowe's, and so they just went there and just ordered what they could find. This was again our setup in a banquet facility. Here they're starting to mark things on the floor, putting floor track. The other thing was they were trying not to disturb this existing facility as much as possible. After this is all done and this is taken apart, whenever that's decided, they have to go back in and fill all these holes and get that to a point like nothing ever happened here before. Now the convention center is used to this because of the trade shows, so it wasn't that big of a deal to them, but there was no, we couldn't punch holes through walls, we couldn't put holes through roofs, we had to deal with the existing condition that we had. They started coming in and laying out electrical. They were doing overhead piping. They were bringing oxygen piping in. You can see here they're just setting things up, all the utilities. By day 5, they're starting to expand the utilities. They're setting up the walls for these patient areas. And you could see these are just little flimsy panels, but once they go up into these frames, they're very nice and tight. The plumbing was all going to be pumped up, so the plumbing, any of the water goes into these sumps, and you'll see there'll be piping that goes up and over. So here we're starting to get more into a shape of an actual patient area. And then this is as it develops. So by day 8, most of the patient areas were set up, the curtains were up, they're starting to put the cabling in. These are the pipes that are going to carry all the sewers, the gray water. This is all the pipe for the oxygen. You could see here that they're starting to build certain areas in the back, some of the storage areas. Right here, this is the, I think the area of the pharmacy. And they put this protective board up front that's wipeable and clean, so they didn't have to paint it. So this is drywall back here, gypsum board, and then they put this panel up front to keep things clean. This was 1 hour rated, so this is rated, and they will put a 1 hour rated ceiling and lid over it, as you can see the studs going by. On day 8, they're still building out things now. This was the area where the nurse station is in that 15 patient area that they had identified originally as ICU. And then more activity going on with construction. This is going to be soiled linen and medical waste holding. So again, following what FGA recommends for these spaces. This is where we had the sink at the end of each one of those bays, and then it went into a sump, and then the sump was pumped up, and this is the water distribution leaving the area. So very efficient. These are the prefab patient showers that we implemented into the space. And then the governor of Michigan, obviously all the the politicians and the dignitaries take the opportunity to visit and see how things are going. So that went well. These are those mobile showers, and now you can see we're building around it to get the space that's required. This was from that second level area that we were at, we could see what a typical patient space looked like with its bed and a chair and the IV pole and then one, oxygen. So you could see the piping running through. They did a phenomenal job. Based on the fact that everything was replicated, I think once you establish the pattern, it worked out well. We created an ambulance canopy. We couldn't attach it to the building, and we did it as quick as we could. So the contractor just hired carpenters and put it together, understanding that it's temporary. All we had to do was provide coverage for them. The pharmacy was being put together. Again, this is day 9 of this. Day 10, we're looking pretty good. The space is starting to fill out. Right now, what they were doing was with mechanical system, they were taking, this was existing, they actually cut this and then they were bringing this down so that they could create low air return to provide the 4 air changes per hour, which was interesting because we had to talk to the building owner in order to get permission to do that. But so long as they brought that back to where it was in the beginning, it was fine. This is where we had those patient showers, the elevated platform, and these are going to be all ADA accessible. Here's where they're building the area for the staff, where they had the mobile showers. This is the doffing area, so they built a self-contained space, and they did this up here, creating a higher area in order to get the air changes out, because of the showers are going to be emitting humidity, and so they wanted to be able to pump that out, so they created a coverage over that. This is going inside of the pharmacy. They got everything framed out, and so they're doing the final wiring. You could see these panels are kind of translucent, which was really nice. And then we did surface mounted lighting. So the space got enough lighting, to operate within the large space. We didn't have any need really to cut into the floor. There was only one space, and I think I have a photograph of that, where we cut into the existing floor. But the main thing was trying to maintain the integrity of the existing system. And then wherever we could, you could see we're extending some of these mechanical shafts in order to provide the air changes. And that was kind of limited in what we could do. But I think this worked out well. And these 2 rooms, being soil, linen, and medical waste holding, these are each 1-hour rated spaces. So I was pleased at how that came about. And then you could see where we're adding the light fixtures are surface mounted. We were providing a system for wireless communication. We've got, again, this staff doffing starting to take shape. Day 11, this is where we had to have one area where we had to cut in. There's a soiled utility space, and we had to cut the floor in order to provide the piping and then the venting to the outside, so that worked out well. Day 11, we've got this is a typical nurse station in between. So on either side of the nurse station are 10 patient spaces, and you could see the hand washing sink. Here's the telecommunication area. We've got fire alarm poles, we've got nurse call. Everything that a hospital needs is put into this, and then the showers coming along nicely. So some of the lessons learned that we had talked about at the beginning and that I showed you is that to do something this quick, the full team needs to be together. And so we had myself, Vince, and then at times Eric at the site, and then back at the, I'm going to say office because they were at home, but I had Camila and Prita, 2 medical planners, and I had Courtney and Natalie, 2 job captains at the ready in case we needed documentation. We put this on BIM 360 in order to provide everybody access. Again, we had a great support staff. It was only, to be honest with you, once it got going, we only needed 4 people to help make this happen. Everybody, it was advantageous that they had Revit and that they had a construction background. The other thing that was interesting is that the Army Corps of Engineers provides all this information, but then you have to make sure that it follows all the state codes, the city codes, the guidelines, and to have the right people, you know, at the right spot, the right time. So we were very, very fortunate. What's next? We don't know. I'll tell you that this facility, we had 250 beds. I think at the most it has had under 30 people. Currently, I think as of like today, there probably are 5 people here. The one in Detroit that was built with 900 people or 900 patients, that one, they actually stopped operations last week. They're not taking it down. They're waiting to see what happens because this might stay in place till the fall, till September. And then they're going to see if it's going to be needed after that. They're thinking that as we get out of the stay-at-home order and things start opening up, if there is an uptick in the amount of COVID cases, then we might have to utilize these spaces again. And now the lessons that we learned is that let us use these spaces for those that have COVID, keep the hospitals running the way they should be running to take the cases, just because like what Anna pointed out, in an emergency room, if we have, you know, COVID mixed in with somebody, say, who broke their arm, the person that broke their arm is going to be hesitant to walk into a place that might have somebody that they could catch something with. And so how do you separate that and how do you think that? So the next thing that, you know, we have to think through is how can we implement what we learned here to the facilities that we're designing now or rethinking about those facilities. One thing I did want to share related to what Anna had shown, and my wife shared this with me today, and Anna, you've probably seen this. I'll move you over here. But elevators. I know that now that I didn't realize that we had this. I know it's been used, but they're looking at, you know, instead of touching, you could kick it or gently push it with your foot to activate the elevator call button. And they would have these installed outside of the elevators to call the elevators, and then have these put into the elevators. Now, I don't know what that looks like when you have like 50 stories. I think, you know, you have to reach up really high or what they're going to do. But those are the kind of the things that we're struggling with now as some of our offices are looking to get into, you know, back into the work environment. So thank you, and that's all I have.
Thank you, Anna and John. And I think we can receive questions from the audience now. Please, whoever has a question, please raise your hand and we will give you the mic. And would you please indicate to whom is a question directed?
Okay, Mr. Muhammad. تفضل.
Yes, actually, thank you very much for Anna and John. Actually, the question for both of them, from planning point of view and for interior point of view, how do you handle and manipulate the patient before they get in this facility? What I mean to say is how you segregate them. Either they have to go directly to home or they have to directly transport to hospital. What kind of safety measures you did to have this area in the triage area at the beginning or entrance of the hospital clean?
For this one here, the one that they did at the convention center, they had you had to be sent there, and so you either had to go through your, like if you had the symptoms, and I think that's still how it is now. You connect with your doctor, and then if the symptoms persist, then they write you a prescription and you go get a test. And the test, they actually had a testing facility here at this site also. And then they would look at what level you had it at. And so if it was something that was extreme, they would send you to a hospital. And then if it was something that can be handled by, being quarantined in an area like this, but you still needed some attention, they had a system of triaging and keeping the area separate. I think they had like 4 separate areas when you came in, so it wasn't like everybody coming in at the same time. They didn't know, actually, to be honest with you, what they were going to expect. So when they first opened up, their first couple of days, I think they had maybe like 4 to 6 patients. So it wasn't that big influx that they thought about, but they did have an area of triage where they could kind of take larger groups, test them, and then if it was something that was more serious, that's why they had the ambulances there. So they had that ambulance canopy. If it was something serious, then they would transport you, directly to the hospital.
Actually, what I feel is I'm worried about this area could be a source of contamination suddenly, because maybe some of this group, some member of that group, large amount of them, all of them, nobody know that they already infected.
Mm-hmm.
So is there any protocol to process in the direction to have or to contain this contaminant people away from the safe person or from the normal person? Maybe they have only coughing.
Yeah, at least unless, well, here in the United States, until they get all the testing to a point where everyone can get tested, like you don't know. And so that's why the big thing is to keep people away from shopping and away from all the activities until they understand who is infected. And even if you get tested positive, you don't know to what level you're at yet.
Yeah.
And so that's being, that's the big struggle here too. So that's something that we don't understand yet. And then that's where even now we're designing a new facility in Kentucky, and there was about an hour and a half last week spent on just the emergency room, like the emergency department, of how do people come in, and then how do you regulate that, and how do you control that, and that's still being reviewed and looked at.
You mentioned in some presentation slides that you maintain some negative pressure, but when I have looked at it, it is completely without sealing or false sealing to contain everything inside.
Correct.
Still, the huge height is still there. So how you achieve that?
Well, and I have some other photographs. The mechanical engineers worked with the mechanical contractors, and they retrofitted some of the existing units, and then they brought in some other units to create kind of like an exhaust. And so they actually created that whole space. It's not like like super scientific, but they actually had a commissioning agent, and they created a negative space, for that huge area. I was surprised that they did it, but they retrofitted it. They had existing doors around the facility, so whichever doors weren't really necessary for exiting, they actually blocked off maybe one of the doors, and they put exhaust there to kind of create that negative environment. Yeah. But again, they couldn't add new units because you didn't want to put anything on the roof, right? Because you don't know what the roof can hold. I didn't want to bring structural engineers. So they did whatever they could down low. And again, they hired a commissioning agent that was there, I think, the last 4 days to look at commissioning all the utilities.
Regarding the gypsum board, you mean to say that the final finish is cleanable and washable, and it could resist the chemical for decontamination process?
Yeah. So what they did was they had the gypsum board, then they put these panels on, and then the panels had the joints, and so they covered the joints, and then they actually had tested it with some of the cleaning agents. And that was the other thing too. There's a whole group there that, like Anna had said, it was like at the end of a shift or the end of the day, you would have the crew come in and clean. Here they would clean like in the morning, then they would clean in the afternoon, then they would clean in the evening. So they're constantly doing that, anything that gets touched, and so they would be wiping down all these surfaces. And again, you have to remember that this is a temporary field hospital. So this is to provide the best care that you can on a temporary basis, but it's not going to be to the level that a hospital is. And yes, I see something, if HEPA filters were used, and there were. The units that they had existing were able to accept the HEPA filter, so they incorporated that also into the design.
Thank you, John. I have a question to Anna, Engineer Ahmed.
Please go ahead.
Yes, Anna, thank you very much for your presentation. Regarding the material used in the furniture itself, is it necessary to use a luxury material in the furniture, as we said, like this, or you are trying to say that we have to deal with the existing furniture, just reducing the number of furniture which is already exists?
We need to do both. We need to reduce the amount of furniture that we have in our waiting areas or cafeteria to reduce the amount of people that we are accepting. And when it goes into fabrics, we are recommending to have vinyls or polypropylene that they are easily cleanable. They can withstand a 10% bleach cleanable solvent. And also we are proposing for the arm caps to be either polypropylene or solid surface, because any wood, if we have any wood or luxurious material, these cleaning solvents are going to destroy them. Not right now, but maybe in 3 to 6 months. We also, if Mr. Kamis will allow, I will be happy to share with you this document where we are keeping a very close monitor and gathering all of the information of the cleaning solvents versus the materials, how they are both coexisting together, because we need to be very careful that we follow the protocols, because if not, the solvents are stronger and it will damage all of the materials.
Thank you very much. Thank you very much.
Thank you, Muhammad. We will move to Mr. Maher Al-Hos.
Can you enter now? I open you. Can you
enter now, Mr. Maher?
Yeah, I can hear you guys. Can you guys hear me?
Yes.
Yes.
Yeah. Hi, Anna. Good to see you again. I have a question for you.
Yes, sir.
Yes, you mentioned something about the walls regarding that we would require to add something to the wall for it to be easily cleanable. And we know that most hospitals today are using paint on the wall, which is, I would say, hospital grade paint. And one of the main reasons that we have in hospitals today is infection control, especially with the pandemic that we're going through today. Do you have any recommendation on what kind of material are you going to use in walls? And I will have another question after that.
Yes, we do. We have several manufacturers do the wall protection. The first one is called Altru, and it is from England. Another one is called Acroban, and I'd be happy to follow up with very detailed manufacturers and recommendations of the level of surfaces that you can apply into the walls.
Okay. You can use Impro. It's the same.
Impro, absolutely, or Impro.
Yeah.
Absolutely.
And you mentioned something very important as well regarding the cubicle curtains, that we're moving more into disposable. So we're no longer going to be seeing any more fabrics curtain which has silver lining inside for, I would say, infection control, correct?
Some cubicle curtains have the silver ions within the fabric, although there's still a lot of research unknown whether it actually works or not into the spread of infection. Well, we're also recommending disposable cubicle curtains are quite expensive, and you don't only have to have the cubicle curtain that is disposable, but the track that it will attach the cubicle curtain. My recommendation is also to clean the cubicle curtains more often. I don't know, in Saudi Arabia and other countries, actually, they do have a better cycle of cleaning the cubicle curtains. In United States, sometimes they clean them every 2 months or so. And that is just unacceptable in now times days. So if it's not for privacy, if the patient, of course, need privacy, we'll recommend it just to close the door and remove the curtain. If the patient does not feel like they have enough privacy, then we do need to leave the cubicle curtain. But either when the patient is discharged, the cubicle curtain goes to cleaning and the new cubicle curtain comes, or you can do disposable curtains.
Okay, all right, great. And one more last question, sorry. Regarding the handrails, are we gonna see a shift of handrails and hospitals from, I would say, wood to PVC?
That's a very good question, because we, by code, we do have to have handrails. But yes, I probably will see moving them more towards PVC because of the cleaning solvents that we need require. Yes.
All right, well, thank you very much. Thank you.
Thank you, Maher.
Thank you.
Any more questions? Okay, well, let's conclude for now. And at the end, I would like to thank our friends in HKS for sharing their valuable knowledge and expertise with us. And I would like also to repeat that we thank Al Umran Society and Saudi Healthcare Architects for giving us this opportunity to share some of the HKS's knowledge, and hopefully to see you again in future presentations. Thank you so much.
Thank you for your time. Thank you.
Thank you for having us, and I know it's a late hour for you.
So we stay late in Ramadan.
Yeah, I know. Yeah, no, but appreciate it. Thank you for allowing us to share.
Okay. Thank you, Ala, for arranging this nice presentation. Thank you, everybody.
Thank you. And then, Ahmed, if anybody needs the documentation that we have, I will be happy to share. I will send everything to Ala.
Great. Thank you so much.
Thank you.
You have a good evening now.
Good evening.
All right.
Thank you for all. Anyone who want certificate for course, can you connect with me in WhatsApp?
شكرا إبراهيم. السلام عليكم.
عليكم السلام. Thank you.
Thank you.
Thank you.